Well, hey there. Welcome to Resident-Centered Care and Managing Aggression in Dementia. This is a PowerPoint about when walking away is appropriate. And hopefully this gives you guys some very much needed tools in your toolbox to protect yourselves and your patients. Some housekeeping stuff. There's a couple of videos at the end of this PowerPoint that I would like you to watch. And then there's a post-test, and I will let you know where that is. So let's get started. So, is it okay to walk away? So the answer is yes. It's not only okay to walk away, it's often the right clinical and safety decision to be making. So in nursing homes, you're allowed and expected to prioritize immediate safety when a resident with dementia becomes physically aggressive. The goal is not to win in the moment. It's to prevent injury, to reset the situation so the care can be delivered safely. I know this sounds a little confusing because everything we've learned all the way up to this point is you hear all about neglect, okay? So I'm going to explain throughout this video and this presentation just why it isn't. When is it appropriate to walk away or create distance? Well, we're going to do that when the resident is swinging, grabbing, biting, kicking, throwing objects, or blocking an exit. If you feel your body tense into a tightening, your body is tensing. This means your body is reacting and it's going into your natural fight or flight mode. And this is your body's safety alarm. It's not a moral flaring. It's definitely not that. And then you got to consider if you're alone. Is it safe to be alone with this patient in this moment? And you have to consider some of the things that are happening around you. So if it's not appropriate to go alone, please do not go alone. What if the resident's escalating despite calm attempts? Those are all appropriate reasons to walk away or create distance between you and the resident. Walking away is not abandonment when you are doing these following things. You're staying within the line of sight if possible. Sometimes we can't do that. So, just make sure you'll hear more as we go. So ensuring the resident is in a safe place, not at immediate risk of falling, eloping, or harming others. You're going to need to call for help, and you're going to initiate the facility's escalation process, which we're going to discuss a little bit more in detail as we go along. So what do you say? How, when a resident is verbally upset or you can see that somebody's upset, and before it gets to the next step, it's okay, and we expect you to say to the resident in a calm, low tone, "You're upset. I'm going to step back to keep us both safe. I'll be right here." So now that creates two things. One, you're setting a boundary in a kind way, and you're also letting them know that you're right there when they're ready. Okay? You're going to call out to your team. It's going to be quick and clear. "I need assistance in room, blah, blah, blah. Resident is escalating with physical aggression." So what to do immediately after you step away? Here's what you're going to do. We're going to create space. So how do we do this? You need to be at least 2 arm lengths away from the person. Near the door, keep an exit path open. So, in other words, your back should be towards the door so you can back out, if that makes any sense. You're going to remove the audience. If there's other residents or extra simulation, multiple people in the room, that could be contributing to the escalation. So multiple people do not need to be there. So yeah, you're going to remove the audience. Again, whether it be other residents, families, extra stimulation, whatever. So you're going to get everybody into a safe place, right? You're going to reduce your demands. You can't tell them to stop. It's just going to escalate the situation. I'm going to use this for example. You have a patient who is restless and they want to walk or they need to do something. We don't know exactly what it is, but regardless, they're not responding to you to say, so-and-so, sit down. So-and-so, sit down. That's just going to agitate them a little bit more. So you need to pause the cares task, whatever it is that you think is important at that moment. Stop explaining, stop arguing until patient calms down. So then you're going to reapproach only when it's safe and with backup if it's needed. Assess at some point, it always helps to assess the cause once the patient is calmish. Are they in pain? Do they need to go to the bathroom? Are they hungry? Do they have an infection? Are they constipated? Overstimulated? Look around the environment. Is there something on the TV that could be upsetting them? You'd be surprised what we put on the TV, the things that we would enjoy, could be a trigger for somebody with dementia or somebody who thinks it might be real. There's multiple reasons why you need to look at your environment. And sometimes it's the smallest things that could be the trigger, but it's good to try to figure out what the trigger is. Okay. So it could be fear. Maybe they're afraid of you. They don't know you. They can't speak your language. They don't understand what you're saying. They've reverted back to their home language. Say they're from Canada and they've spoken French most of their life, and all of a sudden here you are, this person speaking English. They don't understand what you're asking for them to do. So again, that creates a misinterpretation. What if it's a misinterpretation of the way you touched them? Did you explain to them what you were going to do? Teepa Snow has a really, really great segment on that and communication. Just because that patient agreed for you to take their pants down doesn't necessarily understood that you want to take their pants down. Because what Teepa Snow will teach you is that rhythm is on the language on the left, rhythm on the right, and the one thing that we do keep is rhythm. So they only are catching probably about every other word that you might be saying. You take one word out of a sentence and it's really hard to follow the conversation. And I know we've all experienced similar things like that. Could be that there's sundowning. Maybe it's a delirium, and a delirium can be brought on by many, many, many different things. Medication changes, infection, and all kinds of things. And a delirium would be a sudden onset of confusion. It wouldn't be gradual. So I hope that helps you understand things a little better. So let's pause. How are we going to protect the patient, ourselves, and how are we going to move forward, right? How do we proceed? So, one, you need to recognize the early signs of somebody who is in distress. They're restless, they're pacing, they're refusing, their voice is raised. So what are you going to do? You need to slow down, you need to lower your voice, reduce the stimulation around them, offer them some choices, or bring their attention to something else, and reassure them. If it improves, go ahead and continue with the care or whatever it is, the task that you want to move forward with. But if not, and it escalates, now we've moved on to an escalation situation. Now this patient might have some clenched fist. They're yelling. They're starting to swat. So now what do? We're going to stop that task. This is where you stop. You're going to give them some space. What did I say? At least 2 arm lengths away, right? Keep that exit clear. Use calm statement that I told you. I'm going to step back right now, and then you're going to call for support. If it settles, then you can reattempt later, but only after they've fully calmed down. Do not try to reattempt if they're still agitated in any way. Okay? If it escalates to a physical aggression, now we've moved on to this patient is now aggressive, right? They're hitting you, they're biting you, they're throwing things at you. You're going to step away, make sure they're safe, and you're safe. Because let's be real, if they're at this point, this patient is highly likely to get hurt. So the both of you could potentially get hurt. You need to remove others from the situation. You need to notify the nurse. You need to notify. So now we have an incident. This is at this point we have an incident. It is no longer just an escalation. This is an actual situation that must be reported, right? And so we're going to make sure we notify the appropriate people. And then after everything is calmed down, we're going to check everybody for injuries. And then after all that's done, say it ended up into an aggressive interaction. Then we're going to document like a pro, and you're going to protect our team so we can protect our team, right? So what was the antecedent? What was happening right before? What was the care task being done? What was the noise in the environment? What approach was being used? And were they refusing care? No means no. No means come back and reapproach. When I say no means no, that's not, do you want me to shower today or tomorrow? That means, like when you go in and you're like, okay, it's time for your shower, and they say no, then it's no. Behavior is objective. It's never subjective. Often we see a lot of objective statements in a residence chart where we're judging them, and that is not what we should be doing. So an objective statement would be like resident struck staff with closed fist ×2, attempted to bite, etc. Then you want to make sure you put your interventions in. What did you do? We gave them some distance, verbal de-escalation, which would be what I said earlier, removal of the stimuli. Maybe they needed a medication. Who you notified about the behavior, and what was the plan to prevent it from happening again, if that's possible. Because you might need to bring something like this to a team where everybody brainstorms potential plans. Now, all best laid plans, are going to work, but not every plan that we put in place is going to work. Sometimes it's trial and error. And then you want to document the outcome. You got to give this, how long did it take time to settle? How was their response to your intervention? Did anybody get hurt? Did resident or staff get hurt? And again, we're going to continue with the follow-up plan, because now we're not just going to talk about, you can have a plan for an immediate safety, but you still need follow-up plan in the future. And that is where the rest of the team comes in. And this is where the note becomes essential in the chart. So it's very important to follow your facilities process. If the situation escalates, then you need to do an incident report. Why is this important? Well, we need an incident report and workplace violence reporting. Supervisor notification. So this goes a little higher than just the floor staff. This needs to go up into the management team. And then we need to update the care plan and do a behavior plan review, because maybe there's something we can do to modify their plan. And then, of course, we're going to notify the provider, especially if a change in condition is suspected. So here's the big question. Can staff walk away from an aggressive dementia resident? So a lot of times staff are afraid they're going to get in trouble for abandoning the resident, for neglecting the resident. So I'm going to tell you right now, legally and professionally, yes, you definitely can walk away if there's an immediate risk of harm. Staff are allowed to disengage to protect themselves and others. This is considered workplace safety compliance, reasonable clinical judgment, temporary disengagement for de-escalation. It's not abandonment. What makes it not abandonment? It's not abandonment when the resident is not left in immediate medical danger. Now, did you hear me say medical danger? So they're not having a heart attack. They're not, all that kind of stuff. So they're not in immediate medical danger. Staff remain nearby or within observation if the patient's safe. So you can keep them in your eyesight and document all the things they're doing. And if you can't get within 2 arm lengths without them swatting or swinging at you, then yeah, you need to step back because now you're going to get hurt. Okay? Or, so you need to call for help. As long as you're calling for help and then the situation is reassessed and the intent is safety, but not refusal of care.
The commissioner told the judge they didn't have the legal authority to find the vendor. The judge said,
so abandonment would be leaving the building when these things happen. Refusing assigned care entirely. We're just let's not, just because they did this, I'm never taking care of that patient again. That's abandonment. Okay. Ignoring the patient for a long period of time. So typically, I would say keep rechecking every 20 minutes to see if you can get close to the patient. And again, you're going to document how long it took to get into doing that stuff. Okay. Abandonment is if you retaliatory withdrawal of care. So what does that mean exactly? Retaliatory withdrawal of care. You don't like them. This person hurt me, so I'm never taking care of them again. That is retaliatory withdrawal of care. So there's a big difference between I'm stepping out because you're swinging and I'm not taking care of him anymore. Okay, do you see the difference? So it's okay for you to say to the patient, I'm stepping out because you're XYZ. I'll come back when you calm down, or I'm right here. I'll stay in a safe distance so they can see you can see them. That's okay. But you cannot say to any patient, or you cannot refuse, I am not taking care of them. That is abandonment. What do regulators look for on this topic? Surveyors will typically ask, was the resident safe? Was the behavior addressed? Was it documented? Was the care plan updated? Was there a pattern of avoidance? They do not expect staff to endure physical assault. CMS and OSHA both recognize healthcare as a high-risk environment for workplace violence. So, with that said, this is where documentation really, really is important. As long as we're documenting patient refusals, we're documenting that this patient was escalating, so we stepped away. We tried again, it didn't work. We tried again, it didn't work. As long as you're documenting and showing that you're putting effort in, you're good. But if you don't and you just simply refuse to take care of the patient, that's when the surveyors or regulators become unhappy, and that could lead to facility fines, individual fines, even loss of your personal license. So what is the best practice? So best practice supports de-escalation, temporary disengagement. So you're going to temporarily disengage with that person. And then we need a team response. We're going to reattempt when they're calm. We need to do a behavioral plan review. And if a LNA or nurse remains in a situation where they're actively being hit and gets injured, that's not heroic. That is just a system failure. So don't be a hero. I know that you all love your patients and you want the very, very best for them. And I've heard many, many different things. Well, I didn't want them to fall. I didn't want them to get hurt. So when you hear us say they have the right to fall after you've tried to intervene, they have the right to fall. You don't want to get in the way and get yourself hurt. If they're in feces or urine and they're just not wanting you near them and they don't want you to change, it's okay. You're going to keep reapproaching every 20 minutes, right? But don't be a hero, because what does that do? The patient is hurt. It's a lot deeper than that. It definitely gets a lot deeper than that. So, and we're going to go deeper. So here we go. So here's where facilities get it wrong, okay? And where you guys get it wrong. This is like a joint thing. We all have this mindset of, oh, we're just going to deal with it, right? And then we minimize our injuries, and then the behavior plan doesn't get updated. The provider doesn't know about it. We don't know about it. A lot of times I find out about things in hearsay and nothing is anywhere about what happened. So it's a little difficult to track patterns when we're not documenting the patterns, if that makes any sense. So that's when the liability shifts to you as the nurse or as the LNA who are not reporting the patterns. Say you are reporting the patterns and then the facility doesn't do anything about it. Now, this is on every single nurse, not just one. You can't track a pattern by one person documenting the things. It's a team effort, right? So that liability will shift to the facility if everybody does their job. If everybody does their job, well, guess what? It gets a lot more complicated, okay? I hope this is hitting home and you're all understanding what I'm trying to say to you. Okay. So resident-centered care in dementia. Resident-centered care means what? We see the person, not the behavior. So what does that look like, right? A lot of times we'll say, oh, they're doing they just, we label, we got to avoid labeling the person because they're striking out or they're doing this, or labeling them as combative, because usually there's a reason. And one of our patients, several of our patients are veterans, right? So you got this patient, you're coming in, I don't know, maybe, and they got dementia, they're understanding every 2 or 3 words that you're saying, and you go down and you go to touch their pants. You think that they've agreed with you by now. Maybe they did, maybe they didn't. Maybe you didn't tell them what you were doing. And now they're like, okay, I'm being attacked. Now, instead of backing away and reattempting later or trying another approach, you've called somebody else to come in and help you. Now this patient's going to escalate and they're going to start swinging and they're going to get upset, right? Why? Because now they're being attacked and PTSD is setting in. Maybe that person's been in war or whatever. So there's a lot of things that go into this, okay? So point is, we need to adapt the care to them. We do not force them into our routines. Oh, it's time for bed right now, or it's time to get up right now, or oh, it's after dinner and I only have so much time and I got to get to my lunch by 8:30, so let's go. You got to go to bed. That's not okay. If they want to be up till midnight, 2 o'clock, 1 o'clock, 3 o'clock, 4 o'clock in the morning, that's okay. They want to sleep all day or sleep around the clock, that's okay too. We adapt the care to them, not force them into our routine. I said that twice to hopefully that you kind of understand. What if all of you that work, say you've gotten up routinely every day at 3 a.m., right? And then suddenly somebody's like, you get up every day. And so you get up to go to the bathroom. Your normal routine was get up, go to the bathroom, brush your teeth, have your coffee, and do all these other things. And then You come into a facility, you have dementia, and somebody says, guess what? Go back to bed. It's only 3 o'clock in the morning. And I'm thinking, well, I get up at 3 a.m. every day. Or how about what about those people that sleep in until 10 a.m.? So there's that too. People who work 3 to 11 are probably up until 2 or 3 o'clock in the morning. They may go to sleep probably around 10 or 11 in the morning, and then so on and so forth. Maybe you get up around 1 or 2 o'clock in the afternoon. Point is, we're not forcing them into our routines. We need to adjust to them. We need to honor their dignity, honor their history. So get to know them. If you don't know, start talking to the families. We need to do a better job at that. And that's something everybody can improve on. What do they prefer? Maybe I had my hair done every single morning. Maybe I like to put lipstick on every day. Well, we should be doing that. What if they experience some sort of trauma through their life? Right? And then we got to honor the fact that their rhythm is off. As like I said, language, we lose language as in these dementia people lose language, but they don't lose the rhythm. That's why when some people are in a catatonic state, you play some music and you see their little foot tapping, or you hear them humming, or maybe even they actually sing. It's a true thing. So in dementia, behavior is a communication. They're aggressive. So when their behavior begins, it's a communication. They're trying to tell you something. They have a need that we need to meet, right? Aggression is distress. They're protecting themselves and they can't control that. They are in fight or flight. So let's move on. So when a resident lashes out, resident patient-centered care asks, what are they experiencing right now? What are we missing? How did our approach contribute to them lashing out? Right? What would feel safer to them? Not to you, to them. Okay? So this is just food for thought. I want you guys to start thinking about it and really look at them as a person, not as a patient, not as a combative person, not as somebody who lashes out and strikes at you, not as someone who's needy. Okay? This is their home. So now, the hard thing is when somebody's lashing out, somebody's escalating, how can walking away be resident-centered care? Okay? This is the part where we all struggle. Every one of us, because you know what? We love our patients and we want the best for them. So I'm going to tell you that stepping back is not punishment. It's not withdrawal. It's not control. And it's often the most respectful thing you can do for that patient in that moment. When someone is overwhelmed, I want you to think about yourself. How do you feel when you're overwhelmed? Right? When someone is overwhelmed, they're confused, they're scared, they're frightened, they're in pain, and we continue to push through a task. It escalates their fear. Creating space does the exact opposite. It lowers the stimulation. It reduces that perceived threat. It restores their autonomy. So just because somebody has a DPOA, your DPOA cannot tell you to tie their loved one down. Autonomy, we cannot make them take medications. It is still their body, no matter who is in charge of them. Okay? Creating space prevents trauma, protects their dignity. Okay? Sometimes resident patient-centered care means this just isn't the right moment. So forcing patient care is not resident-centered care. And unfortunately, this is happening. And to be blunt, it needs to stop. It needs to stop. And we've got a pattern of this happening, and trying to complete all the task at all cost can only reinforce the fear of you. So if you moving forward with care when a patient is escalating and they're agitated, you're going to make them afraid of all caregivers. And it's going to increase aggression. It's going to be guaranteed to happen in the future. It's going to destroy their trust. It's going to cause an injury for you or for them. So it's going to make all of staff, it'll turn staff into a perceived threat. So if a resident is saying no with their body, their brain cannot, now hear this, they cannot process logic. Resident-centered care respects that neurological reality. So I want you to know that they're not rational in that moment. In the neurological, we respect that. By backing away, you're respecting that neurologically, this isn't the right time. And this patient cannot stop it. And they can't process what you're asking them to do. They can't process any of it. So that's part of why stepping back and giving time and space is highly important. So the balance of safety and dignity. So it's true, resident-centered care includes physiological safety for the resident, physical safety for the staff, flexibility in timing, understanding their triggers, team communication, and if staff are afraid, rushed, injured, or resentful, the care quality will drop, right? A burned out caregiver cannot deliver compassionate dementia care. So protecting your safety preserves resident-centered long-term care. And I hope that makes sense to you. Again, stepping back is expected. So what does it look like in practice? Instead of, we have to get you changed now, it becomes, we'll try again in 20 minutes, right? Instead of holding somebody's arms to finish the hygiene, it becomes stepping away, reassessing. Do they have pain? Or is it something else? Returning with a different caregiver or a different approach. Instead of labeling them as combative, it becomes updating the care plan to reflect the triggers and the best timing. So if we, and that there we go. So how do we do that? Well, that's how we document patterns, right? So we notice in the note every night at 8 p.m., this person has a bowel movement and they become aggressive. So maybe, just maybe, if we toileted them and had them sit in the bathroom at 7 or 7:30 p.m., this whole thing can be avoided, right? So that's where it becomes, and I'm only using that as an example. There are so many others that I could use. So I want you to start looking at things through a trauma-informed lens, okay? Think about the population we're handling and we're taking care of. Many older adults have survived war, they've experienced abuse, and they lived through powerlessness. So what does that mean? We take it for granted, okay? Most of us haven't been to war. Most of this generation has not experienced abuse. And when I say abuse, I mean being whipped with a belt and all kinds of other things. And then lived through powerlessness. Women didn't have rights until 1974. And all of this population was born before 1974. All of this population experienced wars. And a good part of them probably experienced some sort of abuse, right? So when we physically overpower them during their confused state, their nervous system reacts, not their reasoning brain. So if you step back, it interrupts that trauma cycle and it helps them reset. Okay? So really think about that. So, facilities that truly practice resident-centered care do not expect staff to endure assault. We encourage de-escalation over force, update behavior care plans, track patterns, involve the families, review their medications. Sometimes medications could be causing some of these things. Sometimes they need some medications. So that's a delicate balance, right? I know that a lot of you want us to give more meds, but in all reality is it's better for the patient and better for us after reviewing that we review the medications carefully and offer non-pharmacological interventions first. Okay? Because the resident-centered care is not about compliance, it's about a relationship. So start building relationships with your residents instead of looking at them as a patient, so to speak. Build a relationship with them, get to know them, build a relationship with their families. Okay, so the core truth, resident-centered care asks, what does this person need in the moment? So you need to start asking yourself, when you approach a resident, what do they need in the moment, right? Sometimes the answer is they need some reassurance. Maybe they're in pain and they need some pain control. Maybe they need to go to the bathroom. Maybe they just need it to be quiet. How about maybe for some reason I just need a different staff member today. I'm not feeling it with you today. Or do they simply just need some space? And again, I'm going to tell you, space is not abandonment. It's also often the bridge back to a connection. So keep that in mind. Sometimes giving them that space will allow them to allow them to reset, and it will also allow you to calm down and reset. And when you do that step back, please stop and think about what you were doing that maybe potentially triggered the situation. So why does this matter? Resident-centered care and managing aggression and dementia matters because in long-term care, aggression is not rare. But how we respond defines our culture. And resident-centered care means we treat behaviors as communication, right? We adapt our approach. We protect dignity. We protect the staff. These are not competing priorities. They're equally important. So what resident-centered care really means in dementia? Well, it's not completing the task at all cost, winning a power struggle, forcing hygiene because it's scheduled, or enduring a physical assault. It is, however, respecting timing, adjusting our approach, recognizing fear and confusion, protecting safety for everyone. That means you and the resident. When a resident becomes aggressive, the question shifts from how do I get this done to what is this behavior telling me? So behavior equals communication. Okay. Whenever a dementia patient is having a behavior, they're trying to communicate something to you that they can't tell you. So, common causes of aggression. Pain is the number one cause. Okay. So we have this wonderful pain ad scale we could be using, and we could be giving them getting them something for pain, right? Toileting urgency. Maybe they really got to go and you just haven't brought me to the bathroom or whatever, and you all are just hanging out talking, and I got to go to the bathroom, so I'm gonna get agitated. But I can't tell you that's what I need, right? I'm afraid. I'm afraid to be touched. I'm afraid of you. I'm tired. Maybe they're tired. Overstimulation. There's too much going on in the environment, and I just can't handle this stuff right now. And I can tell you, all of us have been there. So if you've been there without dementia and it stresses you out, imagine what it does to them. Okay. Delirium. They even have infection or something's going on. Their medications are causing a delirium. So then we need to do some medication changes, right? And again, I've already told you, sometimes medication causes these behaviors and we don't realize it because that's when, especially when people are on too many medications, right? Maybe they feel like they're losing control, and they just know it. And that could be part of it too. And maybe that when they're losing control, maybe they just need to sit and talk to you for a minute. How many of you have just sat and talked with a resident? I know we're very task oriented and we talk to each other, but how often do you sit and actually have a conversation with the resident? So the brain affected by dementia cannot process logic the way we expect them to, okay? When they're overwhelmed, their body reacts before they can reason. So keep that in mind. That's just their fight or flight comes into play. Okay. So recap. Why is it appropriate to step away? It's appropriate to create distance when the resident is striking, biting, kicking, throwing objects. It's appropriate for you to feel safe. It's appropriate when escalation is increasing. It's appropriate when you're alone and don't have any support. Okay. Stepping away is a de-escalation, protection, and professional judgment. Okay. It is not abandonment. It is not abandonment when residents remain in a safe environment, staff notify the appropriate people, and the situation is reassessed. And then care is attempted later. If you don't go back and attempt that care later, then you have failed. So, why forcing care is not resident-centered care? When we push through resistance, their fear increases, future aggression worsens, trust is damaged, injury risks rises for you and them, and sometimes the most therapeutic intervention is, we'll just try again later. So what should you do in the moment, right? Immediately stop the task. And this is in the moment of aggression or escalation, okay? You're going to immediately stop the task. You're going to step back to a safe distance. I hope everybody remembers how far at the minimum distance that would be. Lower your voice. Keep your body angled. This one's very important, not squared off. So if you turn your body to an angle, like you're going to walk out the door and you're not squaring off with them, when you square off with somebody, it looks like you're ready to fight, right? So if you just angle your body a little bit away from them, it could definitely help calm them a little bit, okay? Maintain a clear exit access. You're going to call for help if needed. And again, if you are upset, I'm going to give you some space. That's another statement you could use. If you're upset, I'm going to give you some space. Then allow their nervous system to settle. Okay?
Competitor, right?
So, say there is an incident and it escalates to aggression. After the aggression of the incident, we're going to check the resident and staff for injuries. You're going to notify nurse management. You're going to document objectively. You're going to try to identify the triggers and look at all the angles of what contributed to the situation. Was it the staff? His approach? Was it something else? Like there's so many things that could come into play. And we're going to update the care plan if the pattern exists and notify the providers of the behavior, whether it's new, worsening, or our non-pharmacological interventions are just not working. So this is how resident-centered care improves over time. So this is a balancing act, right? So balancing resident rights and staff safety, it is definitely a balancing act because there is a fine line between these things, right? But residents do have the right to their dignity and care. Staff also have the right to a safe workplace, and both of these things matter. A caregiver who is injured, afraid, burned out, cannot provide compassionate dementia care. So protecting staff safety sustains resident-centered care long term. And I hope you understand that. So stepping away is appropriate. Okay. It shouldn't be the norm and it shouldn't over time, but it is appropriate. So here's a culture message for staff. We do not expect you to tolerate assault. We do not expect you to, we don't expect you to stay in that situation. We do expect you to stay calm, protect safety, communicate, report patterns, approach each resident with curiosity and not judgment. And my key point is walking away is not giving up. Okay? It's creating space for both you and the resident. So care can happen safely and respectfully. Resident-centered care sometimes look like stepping back before you can step forward. So here's a message from leadership. We are a resident-centered facility that includes emotional safety for residents, physical safety for staff. We do not expect staff to tolerate being hit, kicked, or injured. Walking away to prevent harm is not abandonment when the resident remains safe and the situation is reported. We do expect a calm response, immediate reporting, objective documentation, and team communication. So every incident teaches us something about triggers, timing, and approach. If a staff member was injured, I'm going to tell, if you come to me and you say you were injured, I'm going to tell you, I'm glad that you stepped away. Your safety does matter. So let's review what happened so we can prevent it next time. If you feel guilty, I'm going to tell you right now, don't. You did not fail. Dementia changes the brain. So creating space was appropriate. Okay? And it is appropriate. If patterns are emerging, this tells us something isn't working in the care plan. So let's fix the system, not blame the staff, okay? If speaking to the team, our goal is not task completion at any cost. Our goal is safe, respectful care, okay? Staff may disengage from a resident exhibiting physical aggression when there is a risk of harm, okay? The resident must remain in a safe environment, and the incident must be reported, assessed, documented, and then you need to reattempt care once everything is safe again. So lastly, here are 2 videos I would like you to copy and paste in your browser. I am expecting you to watch these, and then you're gonna do the post test. All right. Thank you for listening, and I want you to write down any questions you had as we went along, or if you had any scenarios you'd like to share, please share them amongst each other, with your teams, with anybody in management, and let's go forward and know that stepping back is not abandonment. Thank you.